Good morning. I'm so pleased to be here to talk about gender-affirming hormone therapy, vascular health, and cardiovascular risk in transgender persons. And I really want to thank Dr. Bond for including this topic in this session, because this is something that's not typically included in women's, heart health sessions. And yet trans women are women too, and deserving of culturally sensitive care and deserving of understanding their unique cardiovascular risks so that we can optimize cardiovascular health in this population. These are my disclosures. They're not related to this topic. So first I'm going to start with some terminology just to make sure we're all on the same page. So first of all, sex and gender are not interchangeable terms. They don't mean the same thing. Generally, when we talk about sex, we're referring to biological sex. In this case, we're talking about the sex that's assigned at birth. So this is typically assigned based on external genitalia. If chromosomes are known, it's assigned by chromosomes or internal gonads. But gender is something different. Gender is a person's internal sense of self and how they fit into the world. It's more of a social cultural role. So a cisgender individual is a person whose sense of personal identity and gender does correspond with their sex assigned at birth. Or transgender persons, this is an umbrella term for persons whose gender identity or expression is a bit different, is different from their sex as assigned at birth. Now, there's some confusion around this. This is different from sexual orientation. Sometimes terminologies of gay or lesbian is applied to this population, and it's important to understand that sexual orientation is actually different from gender identity. So sexual orientation focuses on who people are attracted to. So persons of any gender identity can have any sexual orientation or be asexual. So those are not interchangeable terms either. So in this talk, when I'm talking about a transgender man, this is a person who has a male gender identity and a female assigned sex at birth. A transgender woman is someone with a female gender identity, but male sex assigned at birth. Now, gender is not binary, and there are gender non-binary persons whose gender identity doesn't fall into one of these binary categories of man or woman, and their preferred pronouns may be they or them. So gender dysphoria, I don't really like this term, and it's starting to fall out of favor, but it is something that often U.S. insurance companies often require this diagnosis for payment for transgender medical and surgical interventions. But it means discomfort felt by some persons due to the lack of alignment between their gender identity and their sex that was recorded at birth. It's also important to acknowledge that not all transgender persons have dysphoria. And then there's gender-affirming hormone treatments and surgeries, and this is a broad category of medical interventions that transgender persons might consider to align their appearance and with their gender identity. So I want to acknowledge some important statements that the American Heart Association has done in recent times. So I'm really happy to see major professional societies speaking about this and calling this out. So earlier this year, in 2021, the HA had a scientific statement specifically on the topic I'm talking about today, addressing cardiovascular health in persons who are transgender and gender diverse. And I have some slides from this document. And then last year, another statement, was a bit broader, but it was about cardiovascular health and the LGBTQ community in general, and I was pleased to be able to write a commentary that accompanied this statement. So first, before I get into cardiovascular risk, I want to acknowledge the stress and mental health disorders that are afflicted for individuals who have a gender minority. So there are distal or external stress factors for these individuals related to the discrimination they experience, rejection, victimization, and having other individuals, have non-affirming their gender identity. And then there's internal personal stress factors. There can be internalized transphobia. There can be internalized negative expectations of their self. Concealment of trying to hide or not feeling like they can live their true selves. And this can impact both mental and physical health. But there are some resilience factors, some buffering factors that can be protective, and we want to try to cultivate these. And these are protective factors related to individuals who have a sense of pride for their gender identity and having community connectivity, and that social connectedness and feeling of belonging is so important for everybody. So this is a complicated slide, but how do we go from identity to cardiovascular events risks, which I'm going to lead to, and this is this whole intersectional model. And start with, there's many factors that first of all factor into how we come to have an identity. And then there's individuals, and individuals are in the bigger system, within a healthcare system, within a microsystem, within a macro system. And then there is this bidirectional association of risk factors. So this is not one arrow going forward. These risk factors feed into each other. And these risk factors, I put in these three broad categories from this AHA statement. There's psychosocial risk factors related to depressions, anxiety, stigmatization. I'm going to talk about a little bit more. Then there's behavioral risk factors. Many individuals who are under stress sometimes have adverse coping habits that relate to smoking or excess alcohol use or substance abuse, poor sleep quality or sedentary behavior that impact cardiovascular risk. And then there's the traditional cardiovascular risk factors, blood pressure, dyslipidemia, glucose, that can be impacted by the gender-affirming hormone therapy that I'm going to talk about, but these also related to these other risk factors. These individuals also can be at increased risk for HIV, and this all can contribute to excess cardiovascular risk. So I'm going to be talking a little bit later about gender-affirming hormone therapy and associations in observational studies with excess cardiovascular risk. But again, associations are not causation, and there are a lot of these other cardiovascular risk factors in this population and among these persons that contribute to the excess cardiovascular risk. So it may not be the hormone therapy per se, but the use of gender-affirming hormone therapy is used in persons who have these other shared risk factors. So the impact of mental health. So in this survey, more than half of transgender persons report having a mental health disorder. Depression, anxiety is so prevalent. More than a third report having a current substance use disorder. Now, it's important that gender-affirming hormone therapy may help mitigate some of this risk of depression. So depression, as I mentioned, is very high. But if you look at individuals here on the left columns of who are not using gender-affirming hormone therapy, the risk of depression, the prevalence of depression, is much higher than on the right-hand side of the slide, individuals who are using gender-affirming hormone therapy. And non-treated transgender persons have a fourfold increased risk of depression. So for many individuals, using gender-affirming hormone therapy is a really important part of their gender identity. So I'm going to now move into some potential cardiovascular risk, but I want to acknowledge that this is a really important therapy for many of these individuals. So first, to talk about testosterone therapy. This is typically used in transgender men. Again, female sex assigned at birth, using testosterone therapy for masculinization to have a male gender appearance. Typically, we're using testosterone, a parental IM or a subcutaneous, or you can use a transdermal patch. And we're trying to target blood levels around 300 nanograms per deciliter to have this masculinization appearance. But I just want to put this in context that women typically have testosterone levels around 30, kind of 19 to 60. So we're trying to achieve levels of testosterone that are about 100-fold higher. And so this does likely have some impact on these cardiovascular risk factors, and this is why it's important that we acknowledge that these are really super physiologic doses. Now, we don't have a lot of data on transgender individuals using testosterone therapy. I'm going to share the ones that we do, but I'm going to take a step back and talk about what do we know about testosterone therapy in men, in cis men, and it can have effects with dyslipidemia and glucose intolerance that can lead to inflammation and cardiovascular risk. So looking at some of the data that we have, this is testosterone therapy again. This is cis men, not, I'm going to get back to transgender men. This was an observational study from the VA of men who were older, who have low testosterone levels, and individuals who were treated with testosterone supplementation actually had an excess cardiovascular risk, a 29% excess cardiovascular risk compared to men not using testosterone therapy. But this is observational data, which can be confounded. So what about trials? Well, there's some concerning signals from trials, too. There was the TOM trial. This was, again, older men above 65 who had low testosterone levels. And this trial was stopped early because the men that were assigned to testosterone had fourfold increased risk of cardiovascular events compared to the men in the placebo arm. And then another trial, this was the T trials, this was a CTA trial, again, older men with low testosterone hypogonadism, those randomized to testosterone compared to placebo had increased total plaque on the CTA, the coronary CT angiogram, and more non-calcified plaque, suggesting that testosterone is accelerating atherosclerosis. And again, these were cis men who were older. But because of this, the FDA did, and I will acknowledge that the data is inconclusive. There are studies that have not shown excess cardiovascular risk with testosterone therapy in men, and so there's actually a large trial ongoing now. But based on that data, that enough trials, the FDA has done a warning that about using testosterone products in men who have low levels just due to aging because of this excess risk of heart attacks and strokes. And so it's really reserved for men with low testosterone who actually have symptoms of hypogonadism, but just shouldn't just be used without some thought because of the potential risk. So what about testosterone therapy or testosterone levels in women? So getting back to in women, well, this was looking at blood levels of testosterone. This is some of my work in the MESA study. So at menopause, the ovary stops making estradiol, but the postmenopausal ovary can still produce testosterone for even a decade after menopause. And we looked in this cohort and showed that postmenopausal women who had higher blood levels of testosterone were at excess cardiovascular risk. They had greater risk of having an incident cardiovascular event over the next 12 years, and this was after we adjusted for traditional risk factors, suggesting that excess androgens in women potentially could be harmful. And again, this is older women after menopause, but my lab group did a number of studies where we did show that women with higher androgens had worse cardiac remodeling, aortic stiffness, reduced brachial activity, more plaque progression, again, some worrisome things. But again, keep in mind these were older women after menopause, and typically we're using gender-affirming hormone therapy is often used on much younger individuals. So let's get back to what limited data we have in the transgender individuals. So in this study of transgender men receiving testosterone therapy, they compared their lipid panel before and after the testosterone use and showed that testosterone use in these transgender men was associated with an increase in the triglyceride levels and a drop in HDL levels, so more unfavorable lipid panel. And another study showed that transgender men taking testosterone had worse brachial reactivity, flow-mediated dilation. Now, we don't have trials. We don't have randomized clinical trials, which is what we like to have in cardiology. So I'm going back to observational data, with a reminder that associations don't necessarily mean causation. But in a large gender clinic of trans men who were receiving testosterone therapy, they had a more than threefold increased risk of myocardial infarction compared to other cisgender women in the Netherlands, population-based control women. Now, this busy slide is really this is from US data, the Kaiser data, but ultimately in this cohort of from Kaiser Permanente, there were just so few transgender men taking testosterone therapy. There was like 4 VTE events, 2 stroke events, no MI events, that they really couldn't be conclusive about whether there was or was not any harm. So we have more data about estrogen therapy. So this is used in transgender women, male sex at birth, using estrogen therapy to have a female feminizing gender appearance. And there's options of oral estradiol, which is usually used in 2 to 6 milligrams a day. There's also transdermal patches and IM patches. IM dosing. But let's get back to the oral. So on average, they're sort of using like 5 milligrams per day to try to get to estradiol levels above 100. And just in reference, estradiol that we've been using for postmenopausal hormone therapy is in the range of 1 milligram per deciliter, 1 milligram per day. So, 2 to 6 milligrams per day is, 5-fold higher. And we know that estrogen can be procoagulable, hypercoagulable state and can lead to blood clots. And so there's concern around these dosing. I'm going back, I'm sorry. Also used in transgender women is anti-androgen therapy to suppress testosterone, such as spironolactone or gonadotropin releasing hormone agonists. Also, although they don't have a uterus, many still use progesterone to have a more feminizing appearance as well. So what data do we have about giving estrogens to male men? And going to data, really old data from the 1970s about cis men, we have data from the Coronary Drug Project, which was men who had a prior MI. So these were higher risk cis men. And this is a busy slide because this is Kaplan-Meier curves are from the 1970s. But the bottom line is that they had to stop the trial early because the 5 milligram per day dose of estrogen given to these men was associated with increased cardiovascular risk. And what about estrogen therapy given to women? Well, women in the Women's Health Initiative postmenopause, this is the estrogen-only arm in women with hysterectomy, we did see a 39% increased risk of stroke. And estrogen can have mixed effects on the cardiovascular system. Favorable effects, it can have vasodilatation from a nitric oxide effect and lower LDL. So this is why we think it's, favorable in premenopausal women. But, after menopause or in older women who may have established plaque, the, prothrombotic effects and the pro-inflammatory effects may actually propagate atherosclerosis and lead to plaque rupture, which is why it may contribute to harm in older women who may have established cardiovascular disease. So let's get back to transgender women. So in this observational data, again, from the Gender Clinic in the Netherlands, so trans women who were giving estrogen therapy compared to population-based controls in the Netherlands, that trans women had a 2-fold increased risk of stroke, whether you compared them to cisgender women as the reference or cisgender men as the reference. And they had a 5-fold increased risk of a venous thromboembolism event compared to a cisgender woman or a cisgender man. There was an excess risk of MI only when you compare to cis women, but not to other men. Now, this is US data from Kaiser Permanente looking at venous thromboembolism, and again, kind of see the same thing, this 2-fold increased risk of a VTE event in their population who's using estrogen therapy, both when you compare to cis women and when you compare to cis men. And then for stroke, there was about a 2-fold increased risk when you compare to cis women, which is the graph on the right. It didn't meet statistical significance when you compare to cis men on the left. And also about a 2-fold increased risk of myocardial infarction when you compare to cis women on the right, although not cisgender men. So you see this excess cardiovascular risk. This is more data, again, another Netherlands clinic. And they point out that transgender women in their 51% higher mortality compared to the general population. And this mortality was a lot of things, from suicide, through HIV, through drug use, but also cardiovascular disease. And in this clinic, there was a more than 3-fold increased risk of mortality for individuals who are using estrogen therapy. And this is going back to more data from Kaiser Permanente, looking at, again, those 3 major outcomes, VTE, stroke, and infarction, seeing an excess risk, and it's greater with longer duration of therapy. So I'm not saying that we wouldn't use gender-affirming hormone therapy, because it's really, really important for their gender appearance, but we need to recognize that the underlying cardiovascular risk, and so we need to optimize all the other cardiovascular risk factors, their blood pressure, their glucose, and smoking cessation. And we know that transgender adults have excess burden of cardiovascular risk factors, and a lot of it's underdiagnosed and undertreated because these often are transitioning in younger ages, either adolescence or early adulthood, and sometimes these cardiovascular risks are not made aware of. But 20% can have dyslipidemia, 25% hypertension, 28% smoking, so high burden of cardiovascular risk. And this is something that we can help address. Furthermore, transgender adults have higher estimated cardiovascular risk compared to population controls. This is data from NHANES. If you look at the estimated who have more than a 20% 10-year risk on the right there, you see the blue bars. The transgender have a higher prevalence of these very high risk scores compared to population controls. And on the pie charts, if you look at who has an estimated 10-year risk above 5% among ages 40 to 50, the transgender population, in the blue, are much more likely to be at elevated cardiovascular risk compared to other population controls. So I had the pleasure of being a co-author on the 2019 ACC-AHA primary prevention guidelines, and we did a good job of trying to highlight, all of these what we call risk-enhancing factors that are not included in, risk equations like the pooled cohort equations, and if present, they would favor the initiation of statin in primary prevention. But, notably, transgender it was not listed as a risk-enhancing factor, and should it be? Where does it fit in with risk assessment? And one thing I really use in my clinic a lot when risk is uncertain is I get a coronary artery calcium score, because we know that identifies risk, and that helps guide decisions sometimes about initiation of statins and aspirins. So should we be using coronary artery calcium to help stratify risk in transgender persons? I do, but the question is what age, because generally it takes time for plaque to calcify, and coronary calcium scores are not that useful in younger adults. I usually don't use them until you're over age 40, and many individuals are transitioning, before this age. And then this is something that has to be fixed. There's enormous discrimination in our healthcare system. Surveys have said that 8% have been denied healthcare services based on their sexuality, and 27%, that's nearly a third, have been denied some kind of healthcare service because of being transgender or gender nonconforming. And so, notably so, many transgender adults may not seek out health care because they may worry about how they're going to be treated by the medical community, and they may not feel comfortable. So we need a more welcoming, inclusive environment to facilitate patients to have better partnerships with their clinicians so that we can help improve the cardiovascular care and ultimately their long-term health outcomes. And so it's really imperative that transgender individuals feel safe and comfortable discussing all aspects of their lives and health with the clinicians. And this even starts with simple things about using the right pronouns. Avoidance of care delays the delivery of appropriate preventive lifestyle and pharmacological interventions. So we can't optimize their blood pressure, we can't optimize their lipids, if they don't come see us and we don't even check these values. So in conclusion, transgender individuals are at increased cardiovascular risk compared to their age-matched cisgender counterparts. They have increased prevalence of traditional cardiovascular risk factors. They also have these other burden of discrimination, rejection, victimization, other social stressors, and mental health disorders, depression, anxiety, and there's tremendous mind-body-heart connection. So gender-affirming hormone therapy is really an important part of their gender identity for many, not all, but many, for many transgender persons. And this can help buffer against some mental health disorders like depression. But I think we need to sort out that there can be some potential risks with using these very high supraphysiologic doses related to particularly VTE risk with using estrogens and perhaps increased MI risk with testosterone. And so we really need comprehensive cardiovascular risk assessment to identify and treat other risk factors. And the medical community needs to create universally a safe and non-threatening and supportive environment to provide equitable care. And we're going to ask about preferred pronouns, and we need more research. There's no trials, so we don't really understand exactly what is the safest hormonal therapy preparation to use among the options. These persons are not included in trials, and almost all studies about women's health are really referring to cisgender women and are not including transgender women. So we need more information about how we can mitigate cardiovascular risk in this population. And thank you so much for being here today and letting me talk about this really important topic.